first webinar of the year. Thank you all for joining. Thank you all for joining. Please let us know in the chat where you are joining us from, so we can do a shout out. Who knows, there might be a prize for who comes from the far, who's joining from, zooming in from the farthest. I'm still using star to wait for people to turn up, but let's just start. All right. So good afternoon, everyone. Once again, thank you for joining from wherever you are around the world. Thank you, Bolale, joining from Lagos, Nigeria. My name is Flora Coker. If this is your first time joining us, I'm the founder of Encapsulate Healthcare Solutions. And this organization was born out of a passion for our community to help us make better choices regarding our health by providing health education that presents you with the correct facts and not forwarded message information or superstition. So this platform is to present you with facts related to different issues regarding our health regarding health in our community, so that we can make better choices regarding our health, informed choices, and also we can share it amongst ourselves, so we're sharing the right thing. So that's one of the aims of the organization. And the other thing we do is we provide training for healthcare professionals to improve their skills in wound management. That's one of the areas that I noticed was underserved, and that's what we do. That's a live face-to-face training. The health education programs for the general public are usually online, but for the healthcare professionals, well, before COVID came along, was face-to-face, and we'll hopefully get back to that soon, where we train healthcare professionals in wound management skills. So thank you once again for joining. I am going to hand over to my co-anchor, Dr. Orode.
Good afternoon, everyone. Welcome to Encapsulate Healthcare Solutions. So this afternoon, we have Dr. Olatunde Odusote. He's a consultant pediatrician, an allergologist, and dermatologist. He's the founder and clinical team lead of Allergy and Asthma Clinics, Lagos, Nigeria. He was formerly the head unit of Allergy, Dermatology, and Pulmonary Medicine, Department of Pediatrics and Child Health, Lagos State University Teaching Hospital, Ikeja, Lagos. Dr. Olatunde is a fellow of the Faculty of Pediatrics, National Postgraduate Medical College of Nigeria, and holds a diploma of the College of Family Medicine in Allergology. He's also a fellow of the College of Pediatrics in Allergology, Colleges of Medicine of South Africa. Dr. Olatunde is a chairperson, Allergy and Clinical Immunology. He's a chairperson for the Allergy and Clinical Immunology Society in Nigeria, and a member of other various professional and academic societies, including the Allergy Society of South Africa, European Academy of Allergy and Clinical Immunology, and the American College of Allergy, Asthma, and Immunology. He's passionate about advancing optimal and affordable allergy care in sub-Saharan Africa and has published in reputable national and international journals. Please join me in welcoming Dr. Olatunde, who will be taking charge of the first session. If you have any questions while he's speaking, please feel free to place it in the chat. Thank you.
Thank you very much, already, for that generous introduction. So I'll be sharing my slides now, just to kickstart the first session of my talk. So my first session is just to talk about what's allergy. And so I'm going to start that I have no disclosure, and that this talk is for a general purpose only. It's not supposed to replace seeing your physician or getting advice from the primary care physician. But I'm sure we'll get some form of information that will be helpful during this talk. So let me just start with this cartoon. Like I said, I don't hold the right to this cartoon. It's just to tell you what allergy is all about. Allergy reaction is not overkill. So can you imagine somebody wants to kill a fly and you bring out a sledgehammer? So in the attempt to kill the fly, what happens? You destroy other things. So you can see the sitting room upside down and the fly still escapes. So basically, this is just to capture what allergy reaction is all about. It's like you are trying to do something to something that you should ignore or innocuous like a fly, and you go all out to fight a fly using the wrong equipment. So that's basically this like a focus associate that's all allergy reaction is all about. So by way of definition, so we can say allergy is what happens when a person's immune system reacts to substances that are ignored by most people. For example, that cartoon I just showed you, most people will ignore a fly, especially if you're in some part of Nigeria. If you are up north, like Sokoto, Maiduguri, you probably just say a fly is one of those things you live by. But this guy came out with sledgehammer. So that's the same thing that you see in people with allergy. So their immune system decided to go to war against things most people will just ignore. An example of those things that people are going to just focus on things that are common in our setting, our climate. So house dust mites, cockroaches, rats, pollens, animal danders, food and drug. So, but you'll be amazed at the area of things people can react to, but that's not the essence of this talk. But just to show you that what happens that somebody's body immune system just go to war against something ordinarily you should ignore. So usually our system is built this way, like an infantry or military formation. So you have the ones that are amphibians, they go to war under the sea and all that. You have the infantry, you have the snipers, you have the people that go with night vision, they can fight the war. You have people who, if you are putting up a gas that will want to kill other people, they have a mask, they have the oxygen tank. So the immune system is like an area of many things. So we can say, just because this is a talk for the general population, so we can say the immune system and white blood system is divided to various categories of what they do. So the next thing I'm going to talk about is that our immune system is like a seesaw, and I'm sure a lot of us play with this as a child. So there are two main divisions as well, just for the purpose of our talk. So the T1 angle or arm of the immune system will fight bacterial infection. So it's designed primarily to fight bacterial infection. So once you have an infection that's driven by bacteria, they go to war and try to eliminate that or contain the attack. The two helper cells wing of the thing is supposed to fight passive infection, things that are alive like the worms. But see, the truth that, like I'm sure some of you might be familiar with what we call hygiene hypothesis, where a lot of us, especially in the Western world or in middle upper class in our setting, we have actually partially conquered infection. So we don't, T1 is redundant. So like this seesaw, so if the T1 is redundant, the TH2 is active. So basically what happens with allergies is the angle that's supposed to be fighting parasitic infections now starts looking for trouble. And they look for things that ordinarily should ignore. And then they go to war. And let me say this, they're a familiar tendency. So you have what we call atopy or atopic tendency. So have it runs in family. It's like this genetically programmed to act that way. But see, you can be genetically programmed if the environment is not right. If those things, the environment is not there to trigger off that tendency, then you are all clean. But if you have that tendency and you are exposed to the right triggers, then you manifest the disease. So basically, you have the body that's supposed to protect you. The two wings, the bacterial wing and the other wing that's supposed to fight parasites. But if there is a redundant and you have a tendency to have those reactions, like I underline that a tendency to have those reactions, then your body goes to war and fights needless war. So this is not supposed to be what you look at least. I just put it, I just tell you, it's an area of cells that are activated, and then the area you should focus on that when there's a trigger, you produce this immunoglobulin IgE. And once they dock on your mast cells or basophil cells, they degranulate. So this thing that they're releasing are the things that produce the reaction you see. The hives, the angioedema, the itching, the sneezing, the coughing. So that's basically what I showed you. I don't intend to have this, know it is in depth, but just show you. So what are the things you see when you have this chemical reaction because of that redundancy of the cells? What do you see? So sign will be, you find somebody's coughing, somebody's wheezing, you can have tightening of chest, they say, or they become breathless, and that is in keeping what you see in people with asthma. So for example, if you have hives or wheels or angioedema, so somebody who have a reaction to food or a reaction to some other things, it could be food, drug, or even sometimes, like we talk about something like urticaria, can be spontaneous or could be chronic. And you see hives and angioedema. But other conditions like anaphylaxis and some severe reaction. There's sneezing, also you see sneezing, runny nose, and the runny will be clear fluids, and then itching. So itching is common immune allergic condition, and it's because one of the chemicals produced during that reaction is histamine, and histamine will cause itching. So basically, just a summary of the signs that you see in somebody who has allergy. And so just to bring the point home, this is hives. This is what it looks like on a normal blood skin. To just have this bump, and I'm sure some of us have had this. And the way to bring it down, I'm sure if you are bitten by a sandfly, you have a bump like this. So that's what we call hives or wheals. Then angioedema also means that you just have swollen lips, swollen eyes, following an allergic reaction. So that's basically what it is. So in a nutshell, what I'm just trying to give us in an overview of what's an allergy. So basically, you go to war, deploy the warfare where you need to ignore things, and then the things you see, things I talked about as signs of allergy. The cough, wheezing, and I'm sure as we go along this talk, I'll probably give more information, but they'll just give an overview of what happens. Thank you very much for listening. So I'll be willing to take questions now, and then maybe I'll shed more light on something that I've talked about. Thank you.
Okay, thank you for that first session. We have a question in the chat from Mr. Kunle. And the question is it possible to have... Oh, I thought it was a question relating to your presentation. Mr. Kunle, we've answered that for you in the chat. Do we have any questions about what an allergy is before we move on? If you can just raise your hand, if you're trying to type, you can just raise your hand, and that would make it faster. And then we can take your question. Okay, while we're waiting. So in terms of what an allergy is it just anything can cause an allergy, or is it just, can you predict who's going to have an allergy? Or
so okay, well, in terms of like I mentioned in talk, the truth is that there's usually a familial tendency. So it runs family. So, but that tendency is there, but you have to have an environmental factor to trigger it. For example, if you are a twin and your twin, an identical twin, for example.
We can't hear you.
Okay, so
yeah, we can hear you now.
Okay, sorry. So I'm saying that number one, there's a familiar tendency. So you have to have that tendency that runs the family. So I'll give an example of identical twins. So if one with twin is allergic, then the chance that about 90% the second twin like to be have same problem. If they are not identical twins, it's like a brother or sibling. So if one has, the chances might not be up to 80%, maybe 30, 50% or about. A mother or father has an allergy within the nuclear family, you can say what the children in that like to have tendency. So in that of predicting it, so if a father, mother, or sibling, one of the siblings has an allergic reaction, then you should look closer to other people. But like I said, you must have that trigger factor in the environment that sets it all up. I hope I've answered the question.
Yes, thank you. All right. Do we have any more questions regarding allergies in general? Okay, we have a question from Beulah. Is it possible to develop allergies later in life?
I would say yes. There's some type of allergies you can develop later in life. So some of the ones I will talk about, you like, so let me say, if it's food allergy, you don't like to have the class 1 food allergy, like if you have been eating peanuts, granules, egg, and all that. The chance that you develop de novo allergies like to be very rare. But there are some class 2 food allergy that can develop, which cause a cross reaction between the antigen. For example, if you have hay fever allergic rhinitis, and it's driven by house dust mites. Because house dust mites and shrimps, prawns, and some of the seafood have similar protein, right? There can still be some cross reaction, but the kind of reaction you have will be very mild reaction. Maybe you are eating prawns, your mouth is itching, tingling, you have a small, just feel uncomfortable, but you don't have the full-blown stuff. So that's the kind of thing I would say to you. But but you can have some other allergy, like maybe like chronic spontaneous urticaria. It can occur for the first time in an adult, right? So, but there's some type of allergy that will not occur in adults, but there's some other types. For example, if you have atopic dermatitis, it's not likely to have to start as an adult. You have had those things. But if you have contact dermatitis, like for example, you work in a place where you work with chemicals that you react to, then that can come as an adult. So it's yes and no, depending on what kind of allergy you're talking about. For example, asthma can occur for the first time in adults. There's some variant of asthma that occur in older women, fat and all that. So that's the kind of thing that we can speak to. Thank you.
Thank you, Dr. Odushote. Please, could you increase your volume a bit? Because when you were speaking first, I think it was breaking a little.
Okay.
To make it a bit louder.
Okay.
All right. If there are no more questions, you can carry on and let's discuss about the types of allergies. Thank you.
Okay. Sorry, let me go back. So what are the types of allergy that you have? This by all means not an exhaustive list, but because of our time limits, and I'm sure if there's caution, I can speak to other common ones. But I don't speak this one because they're the common ones I like to encounter. So asthma, bronchial asthma, is a form of allergy. Allergic rhinitis, I will speak to that. Allergic conjunctivitis, I will also speak to that. But let me say this, asthma and allergic rhinitis, we now treat them as one disease. The principle of what we call united airway disease. That means what happens in your nose will like to happen to your chest because the same passage. You can see that there's a connection between your nose, your throat, your lungs, right? So more often than not, when we see allergy in asthma or rhinitis, we look for asthma. And like a small study we did, found out that most people have asthma and their allergic rhinitis was never treated. And that will make them struggle with their asthma. So allergic conjunctivitis, there's also a small tract between the nose and the eye. So you can also have that component. So you look for it when you have that. Atopic dermatitis is the inflammation or the allergy of the skin. Usually that starts from childhood, usually from the age of more than not from 2 months, and it will continue in lifespan. So the good news about that, some people are treated with the disease, but some people still continue to have it as an adult. Contact dermatitis is just when you react to things that come to with your skin. Food allergy is you can practically react to any food under the sun, but I will speak to that in some details as we go along. So I try to put this in the list, chronic spontaneous urticaria, because I've actually seen a couple of people that I've seen who have been mismanaged by people for some wrong reasons. So I just think I need to talk about that. So if you are in that group, you can seek help in the right direction. Then drug allergy, like any drug can actually be allergic, can be allergic to, but sometimes there's some misdiagnosis, especially with penicillin allergy. There's a lot of overdiagnosis of penicillin allergy. That if there's a question, I can answer that. But hey, you can react to drug. So I just put this graph there to show that there's something they call allergic match. So what happens that is not perfect, but that you start out either with atopic dermatitis or what call it eczema or food allergy, and then as you are trying to wane or outgrow that, then asthma comes in, like this comes. So what this says to us that once you have one allergy, especially if you start out, then we should track you and ensure we don't miss out. Like I said, it's not a perfect thing, but the truth that we just said, which is like monitoring people over the years, you can see 0. Sometimes, like I told you, that atopic dermatitis can go down and from the track. Asthma will start a little bit later, allergies will start a little bit later. You can see that both of them actually are like a twin going together after a while, whereas this one are going down. So that's basically what it is. So I'll just speak to a few of them so that we can know how they present. So asthma, for example, you have somebody who starts coughing suddenly, and the cough is usually dry cough. They're not is dry cough. It can start really at night, but first in the morning, and they will wheeze. So they have a wheezing sound like, when you listen to closely at the stethoscope. If it's very bad, you can actually hear it when you put your hair on their chest. They become breathless or fast breathing. Suddenly, they're coughing, they become breathless as if they have just finished running 100-meter dash. And they have chest tightness, as if something is holding their chest tightly, or chest pain. And one of the things that you can really use as a layman to determine how bad the asthma is inability to make complete sentences. See, for you to be able to speak, you have to be able to excel here. So if you are not able, and if you're asthma, they can take in air, but they cannot excel. And so if a child has asthma and cannot speak like I'm speaking to you fluently, then you know that that child is in trouble. So as a layman, you can use it as a guide to know when to seek for help. So that's in a nutshell how asthma, you can expect somebody with asthma. Sudden cough, breathlessness, chest tightness, and the ability to make complete sentences. And that's what you tend to see. With rhinitis, at least, the thing that people can confuse it with cold, common cold. That's one of the things that people do. But you see, in rhinitis, itchy nose is constant. Cold will not give you itchy nose. So if your nose is itching, you're sneezing repeatedly, especially when you wake up in the morning, or you have runny nose, and a runny nose is really clear fluid. And then you have nasal congestion. That means your nose is blocked. So itchiness of the nose, sneezing, running nose, and usually is clear fluid initially, but can become secondary bacterial infected. And then you have nasal congestion, blocked nose. Then, especially with itchy, and it's recurrent, especially if you are exposed to some triggers, you know that certain things brings on. But I can say in some other people is non-allergic triggers. Sometimes if you eat, like I'm sure some of us, we are familiar with this part of where I come from, Southwest. When you are sick, they give you hot pepper to drink. That will make your nose run, right? But will not itch. So, and then the thing about rhinitis that I want to emphasize is the quality of sleep is very poor. So it will not kill you, but will make you miserable. So you can find that you wake up tired, you are not able to function well at work. In the child, you have a very bad school performance because they're sleepy and all of that. So rhinitis will not kill you, but will make your life miserable. So conjunctivitis is the team, like a Siamese triplet, as if you want to call it that way. So the thing to see is that you have itchy eyes. They usually eat their eyes. Their eyes is really brownish, what we call muddy sclera. So brownish eyes. They can have watery eye discharge. The discharge is whitish, is not the colored one. And they can have what we call blepharospasm. They blink a lot because we have severe disease. So basically, what you see with them is that their eyes is really itchy. Their eyes look brownish. It's not red. Yeah, the Apollo is red, but this is like a brown, like you have mud. The sclera look muddy. And then watery discharge, and they have white discharge. But more often than not, they will find that it causes season and it can be constant depending on what they are allergic to. So that's in a nutshell what you see conjunctivitis. So atopic dermatitis is actually very common in children, but like I said, people are with that disease. So sometimes before they enter primary school, about 50% will have that disease. By the time they are puberty, going to secondary school, and that 25%, only very few, 20% that gets to adulthood with the disease that progresses. So you have the itchy rash, itchiness is constant, typical rash, usually is chronic or comes off and on. So chronic means it'll be on there for 6 months and more, or can be going and coming in the last 6 months. This also, I say, with poor sleep quality, if not properly taken care of. And then you can have second bacterial infection, viral infection, and their life can be very miserable. And this can also affect them. So I just want to show you what it looks like. So you can see this child has this rash here, under the armpits, and all that. Usually they also tend to have very dry skin. Now, one of the hallmarks that you can really see if you have somebody who has that tendency is what we call chicken skin. Now, when you the skin, you remove the feather of the skin of the chicken, you see this bump there, you see that. So if you see that in the tummy of a child and you take history that they have families of atopy and they have dry skin, that could be the beginning of the process. And those children, what we usually advise that you ensure you use very mild soap or soap substitute to bathe them and moisturize their skin very well, because that could be a setup for atopic dermatitis. So this is what you see in, so it can be, if it's acute, it'll be red. Usually there's some area affected here, around the neck, the cheeks in younger children, behind the knee, and stuff like that. So usually it's very itchy. So food allergy, we'll just spend some time here. Any food like that under the sun, you can react to. But there's a big 6 or 7 that people will talk about. So things like, you start with milk, cow's milk. You also think egg. You saw groundnut or peanut. You talk about fish, whether shellfish, or you have regular fish. Then wheat can be something, or soya thing. That's a big group. But like I said, anything, and even fruits, apple, banana, people are reactive to the berries, people have the wheat berry and stuff like that. Even mango. There are cases of people who not, they can eat apple, but if the seed of the apple touches their body, they will have severe reaction. So there's a lot of things. But the key thing in food allergy, and I want to emphasize that, once you eat the food anytime, the key thing, every time you eat the food, within 5 minutes to 2 hours, you have a reaction. So it will not be right to say, I have a food allergy, I can eat it sometimes, and I have no problem. I eat again, I have problems. A food allergy, every time you eat the food, you react. And what you have, we have grades. We have what we call cutaneous manifestation, so that you see on your skin, which is hives and angioedema. What I showed before, that just have bumps, and then can be swollen lips, swollen eyes, just swelling around the body. That's what we call the cutaneous or skin manifestation of the reaction. More often than not, we have a type 1 allergy reaction, like food allergy, you see that. That's the entry level. And that's we consider to be mild. So if all you have is skin manifestation to food, we say it's mild, but we still have things to do as we talk about treatment. I'll talk about. So, but sometimes people have respiratory components. So you can have cutaneous skin manifestation, and respiratory component will be, person is coughing, is wheezing, chest is closing up, is not be able to breathe properly. That is a respiratory component, and you can see that in a food allergy. So what we usually say, if you have, so it can be cardiovascular problem, so you have blood pressure drops rapidly, or they faint and all that. So that is also what we see in food, can see that in food allergy. If it's due to involvement of gastrointestinal tract that they got, then they can actually vomit, they can have abdominal pain, they can stool, and all of that. If it's CNS, they just collapse. So what we tend to do, the most severe form of allergy is what we call anaphylaxis. So if you have any of these two combined, so you see after exposure to arise, what you react to, you have skin manifestation, and you have respiratory or cardiovascular system, or in any combination, then you should diagnose anaphylaxis, and there's a way to treat that, because that can lead to death. The other thing, that if you have rapid drop in blood pressure alone, they can make a diagnosis of anaphylaxis. But if it just came manifestation, that's a mild one, and there's a way to treat that. But it's important for us to know what food allergy entails, because I've seen people come to me and say, I have food allergy. And when you take this history, find that they don't have allergy, because, like I said, every time you eat the food, within 5 minutes to 2 hours, 5 minutes to 2 hours, you have all these symptoms. That's the typical food allergy as driven by type 1 IgE. But there's another one that's not immune driven, we call non-immune mediated, and that's a big group, and I don't want to bore us with that. But that's not really life-threatening, but it can be miserable, they can lose weight, and there's another big group, which we take a lot of time to talk about it. So I try to put this in, which is chronic spontaneous urticaria. See, people have urticaria, and we call it chronic if it's been coming and going in for more than 6 weeks. And there are 2 pathways where you can have that. We say it's chronic spontaneous, that if you don't do anything, it just comes of you without doing it. So usually when you come to the clinic, I ask you, is there anything you do to bring this thing on? I say, no, it just comes up. You can be seated in your office, you have hives, or you have swollen lips, swollen face. That does not, I don't do anything, it just comes up and it's recurrent. Or it can be induced by physical factors. Like, for example, if you wear tight clothes, or you carry a bag, your knapsack that's heavy, it's as if those areas will now develop swelling or angioedema. Or sudden change in temperature, you bathe with very cold water, or you use warm water, or sometimes when you exercise, some people when they exercise, they have this problem. So So when you come to us, we ask you, is there anything that you do to bring it on? But most people think it's food. And if you look at what I told you about food, more often than not, is not like that. In urticaria, you have angioedema and all that, but it'll be off and on for more than 6 weeks. And if you take history of a dietary history, you find that none of those things, you have a long list of food, none of them. And like I said, for more often than not, a food you have been eating before now will not suddenly give you this. And that's one of the reasons why we exclude that. But if it's something that costs less than 6 weeks for the first time, then you can think of food as a cause. Or you can think of something you had, maybe a preservative you put in your food, or something that's driving the food and that's causing the problem. Or another big thing that causes urticaria, less than that cause acutely, will be infection. Bacterial infection, viral infection, parasitic infection can cause those things. Other big thing that can cause that, if you have autoimmune diseases, that can also be a concern. Or if you have thyroid issues. So anything that autoimmune disease can result in all this. But more often than not, this is usually being not managed properly in environment. So I think that not just to cover some ground, but like I said, what I've just done is just an overview. And if there are questions about some types that you want me to speak to, I can do that. Thank you very much.
Thank you. Thank you, Dr. Olatunde. Okay, do we have any questions regarding the types of allergies? Any questions? Dr. Olatunde, could you just, when you talk about urticaria, what exactly is that, just in layman's terms, and also about the, was it dermatitis? And yeah, what do they mean in layman's terms, please?
So urticaria just mean swelling, like that's what I'm showing you this picture, hives. So when you have these hives that's recurring off and on, sometimes like I said, you have not done anything, it just comes on, or you have angioedema, just swollen lips, eyes without anything. So if it's been going on and off for 6 weeks or more, then we call it chronic urticaria. It can be spontaneous. That means there's nothing, you're not doing anything. So if you just
Your
look at,
network was breaking.
is it breaking again? Sorry. Can you hear me now?
Go on.
So
Yes.
I'm saying if it's spontaneous, it means you are not doing anything. It just comes out. If you ask you, is there anything you do to bring it out? Say, no, it just comes up. But sometimes it's physically induced. It means you can be pressure, like you carry a heavy load or wear a tight dress, or you are supposed to change the temperature. It could be cold water, warm water. It could be exercise, some that change your internal temperature. So that will be physically induced urticaria. So the other thing I speak to is that even if it's an acute one, that means the one that been occurring less than 6 weeks, it can be due to food. And I said the food component can be cutaneous manifestation, where you have, when you eat the food, let's just say you take shrimp. Every time you eat shrimp, you have hives like this, and you have angioedema. Sometimes it can progress to your chest closing up. If it progresses to that side, that means you have a severe form of reaction. So, but urticaria just means you have hives like this. This is what urticaria means, just have hives. And it's because some of the chemicals your body produces, histamine, will result in this. That's basically what it is. I hope I've been able to answer the question now.
Yes, thank you. I'm just going to put off my video for a minute. It's telling me my internet is unstable. Okay, we have a few questions for you. What kind of food should be avoided in someone with asthma? Now, the person has written it as asthma allergy, but I deliberately said it the other way. So what kind of food should someone with asthma avoid, if any?
Well, the truth is that asthma in itself is not caused by food.
Mm-hmm.
Right? It's not caused by food. But so usually what we know that actually triggers asthma will be things you inhale, right? I.e. dust mites, animal dander, cockroach, and stuff like that. But there are people who have asthma. They also have food allergy. What I can say is that if you have asthma and food allergy, the risk of dying, of having a dangerous lifestyle or severe form of food allergy is high. So what we tend to do that if you have a food allergy, we ensure we optimize your asthma because it's like a double jeopardy. But asthma is not driven by food allergy. More often than not, it's something that you inhale that causes those setup. But you can have asthma and also have a food allergy, but not the two together. The only exception to that rule, I would say, it's not even the food per se, is that in adults, what we call occasional asthma. For example, if you work in a place where you inhale a lot of things, you might have underlying asthma. No, we say you have a typical tendency. If you are not exposed to that environment, you don't have that. So some people work in some fish handling places or where they inhale a lot of chemicals, paint industries and stuff like that, or they inhale a lot of mold, then they can have severe asthma, or they can have a what we call occasional asthma. So that is another ball game, but it's not really the food, it's what they inhale that's causing problems. So if you have what we call baker's asthma, for example, some people work in bakeries also, and they inhale those things. So that is what we call occasional asthma. So you can have asthma in itself that's well controlled, and if you work in that environment, it can make your asthma worse. So find that a person has asthma that's well controlled. When he goes to work, is has very severe disease. But if he's on vacation, he's all well. So that's the other group, but it's not the food per se. It's because they are inhaling something in the environment where they work, either in the bakery, in the fish handling process, or in paint factory. And that's basically what it is. It's not the food per se, it's what they inhale. So asthma is usually driven by what you inhale, the aspectally.
Thank you. Thank you for that. The next question is eczema an allergic condition? And is it the same as atopic dermatitis?
Yes. Atopic dermatitis is same thing as atopic eczema. And that's a common name that we use interchangeably in allergy. There are some older names that have been dropped. So if you say atopic dermatitis or atopic eczema, more often than not, you're speaking about the same thing. And that's what it is.
All right. Okay. So there's one here about pregnancy. Can pregnancy induce allergic rhinitis, which lingers for about 7 months after delivery?
Well, so the thing about pregnancy is the fact that your immune level is reduced. Obviously, you have that tendency before. It's not pregnancy itself that's causing the allergic rhinitis. But we also know that with hormonal imbalance, some allergic reaction can be worse, right? There's something we call a triad. You have allergic rhinitis, you have polyps, and a few other things that can be worse with pregnancy, that can be worse with use of some medications and all of that. So in a way, more often than not, you have that tendency. Because in pregnancy, your hormone, your immune system is compromised. See, pregnancy, what happens that for you to sustain a pregnancy, the baby you're carrying is a foreign protein, let me put that way, just to us. So your body is in a tolerance mode, right? So a few things can be thrown up because your body is able to be quiet and all that. So also hormonal changes can affect your system, the way your immune system reacts. But more often than not, you have those reactions. And there are other things that are common in pregnancy, which after the delivery, you will go away. But more often than not, I would say pregnancy itself does not make it common, is because we have those tendencies initially. Thank you.
Thank you. Thank you. And then one more before we go on to the next speaker. We'll take the rest of the questions later. In the case of itchy nose and sneezing, what is recommended as treatment?
Well, like I said, this is not supposed to be. So I'll say to you, see a doctor. But within the next part, I will mention some few things I do, but I won't prescribe any medication. But my next talk, I will talk about treatment modalities. I'm sure you probably be able to, when you see your doctors, when they are prescribing things, you probably say, okay, you had somebody speak about this, but I won't make anything, but I will be able to guide you about what to ask for without giving you a prescription. Thank you.
Thank you. Please stop sharing. So we'll go to the next speaker and then we'll come back to you, Dr. Olatunde. All right. Dr. Orode, over to you. Thank you.
Okay, thank you so much, Dr. Olatunde. Our next speaker is pharmacist Folashade Olufunke. She's the fellow of the Pharmaceutical Society of Nigeria, fellow Nigeria Academy of Pharmacy, the medical director of Victory Drugs and proprietor Victory Vaccine Clinic. She's passionate about preventive health and rational use of medicines. She will be taking us through medicines and allergies. So over to you, Mrs. Lawal.
Good afternoon, everyone. Can you hear me?
Yes, we can.
Okay. So good afternoon, everyone. I'm highly delighted to be with us again. Sorry, let me get my slides well. Yes. Thank you, Dr. Dushote. You've done greatly on allergies, and I'm just going to handle a very minor part of it, drug allergies. And like Dr. Dushote said, this is just for information purposes. It's not intended to take the place of your doctor's advice. We're just here to learn, and nobody is paying us to do this. We're just sharing knowledge. So I will take us briefly through the world of drug allergies. And this is my outline. We'll look at an introduction. We try to look at the difference between drug allergy side effects and when we talk about drug toxicity, then we look at effects of drug allergy, common causes of drug allergy, how to avoid drug allergy, and then managing drug allergy. I always say this, drugs or medications are very useful. They are meant to help, but once we put them in, it's difficult to tell it what to do. So we must use drugs when needed and as directed by our prescriber and the pharmacist. So briefly, drug allergy occurs when the body's immune system imagines or perceives that a normally harmless substance is a medication in a medication is a harmful invader, and then it overreacts. Dr. Odushote spoke a lot about it. It's like carrying a gun to want to shoot a mosquito. So the body just decides to overreact, and it's not anybody's fault. It's one of the 10 most common allergies. You'll find it on Dr. Odushote's list. He told us it's not exhaustive, but drug allergy finds its way there. Drug allergies account for 5 to 10% of adverse drug reactions. So there's a broader term called adverse drug reactions. And out of adverse drug reactions, generally, drug allergies account for 5 to 10%. Now, drug allergy can lead to hospitalization and sometimes may be life-threatening. And that's why it's important that we speak about it. So I will briefly take us through drug allergy side effects and what we call drug toxicity. Like we said, drug allergy has to do with the body's immune system. It's mediated by the immune system. So it's different from side effects. Side effects they are known possible reactions to a drug. They may be beneficial sometimes. I'm sure some of us know that some drugs like we use for itching might also make us drowsy. And for that reason, we may want to use it so that we sleep off the itchiness. So sometimes the side effects are beneficial. Sometimes they're just neutral like that, or they may not be. They're usually listed in the medicine label or insert. So if you buy a medication and you read through, you're likely to see a list of side effects. Most of those side effects don't necessarily happen. Most of them don't, but they have to be listed because there's a possibility that one or two of them might happen. So examples of side effects include drowsiness, nausea, vomiting, diarrhea, photosensitivity. I recall when my son was very, very small, he read through the literature of one drug and he counted about 40 side effects and he shouted, this one medicine, only this one medicine, 40 side effects. And I said, don't shout, don't be alarmed. They just have to be stated there. Doesn't mean that when you swallow it, all these 40 things will happen to you, not at all. So drugs are meant to help. Once they are properly, we are probably properly guided and we're using them as needed, prescribed by the right persons, dispensed by those who are also trained to do so, and we are ready to follow instructions. Now, drug toxicity is adverse reaction due to overdose. If we use more than we should use, then we are likely to get drug toxicity. I hope I've been able to show the difference in that brief slide. So what are drugs that cause allergy? Any medicine at all can cause drug allergy, whether they are prescribed, whether they are herbals, over the counter. Injected. I want us to notice allergy can occur to any medicine. Sometimes to sell products, some people will tell you that this is herbal, cannot have any form of reaction. It's not necessarily true. Any medicine can cause drug allergy. Now, usually for a medicine to cause allergy, the person must have been exposed to it or a similar medicine somehow before, because it's about the body's immune system and a chain of reactions. So the early exposure usually prompts the immune cells to form antibodies against the drug. The body is just trying to protect itself, or imagine that it's under a terrorist attack and wants to just defend itself, and in the process it might harm itself. Now, subsequent exposure to the medicine, these antibodies go into action and they set off what we call the allergic response. Now, symptoms of drug allergy, they're also similar to symptoms of some other allergies. You can have itching, skin rash, urticaria or hives. Dr. Olushote talked a lot about that. There could be breathing problems such as wheezing or shortness of breath. There might be swellings. You might have swelling on your face. I know somebody who took a malaria medicine and the face swelled. So sometimes there may be swelling on the face. There may be feeling of dizziness or lightheadedness. There could be runny nose. Anaphylaxis, the patient told us about it. It's rare that it happens, but it can be life-threatening. There could be what we call serum sickness, drug-induced anemia. This is not exhaustive, but this gives an idea. Now, it's worthy of note that a drug allergy can occur on any part of our body. So most common causes of drug allergies, antibiotics, the beta-lactams, we call them, or penicillin and its relatives. Like Dr. Dushote rightly said, it's overdiagnosed penicillin allergies. And over time, we've been found that about 90% of the so-called allergies are not really there. But like we have said, this is just for information purpose. Please follow through with your doctor's advice. There are also some other antibiotics that are known to cause allergies, like sulfur-containing drugs, like sulfamethoxazole, trimethoprim, I think popularly called Septrin in our environment, just for us to have an idea what that drug is. There are many brands, they have different names. Some people might just, for whatever reason, have allergies to it. It's not very common, but it's good for us to know that it can happen. Interestingly, I know somebody who had allergy to the metabolite of a drug the drug was metabolized into sulfur. that means that that drug on its own was not necessarily a sulfur drug, but when it was broken down, it had a sulfur component and that person reacted. It's very rare that these things occur, but it's good to know that it can occur so that we protect ourselves. Then aspirin and other, we call them non-steroidal anti-inflammatory drugs. They are generally painkillers like ibuprofen and co, especially in asthma patients. About 20% of them are likely to have allergies to aspirin. Then some group of anticonvulsants, chemotherapy drugs. This is not exhaustive, but common causes of allergy. Like we said, remember, any medicine can produce a drug allergy. Now, how do we prevent drug allergies? Simple. Avoid that medication. Unfortunately, that may not work because sometimes you won't even know that it can give you an allergy before you use it. So it's good to ask questions about any medication, including herbs, before you take or use them. Whether they're supplements, ask questions. Please, please do. Don't assume that they're all, nothing can happen. So ask questions. Are there likely problems? Are there reported issues? And then one other thing that is very important, really, the way I see God has designed it, most of the time, the first allergies, but subsequent ones might be worse. So once you have a drug allergy that is queryable, that we're not comfortable with, and you discuss with your healthcare professional or doctor, and they say, don't take that drug again, then please don't take it again. So you need to take note of any drug allergy you ever experience and share that knowledge with your pharmacist or other healthcare professional. I keep saying pharmacist because that is our field. You will see that they've narrowed me to drug and medication because I'm a pharmacist. That's what I'm trained to do. Find out more about any drug that ever gave you an allergy. For example, if you've ever had allergy to penicillin, it may predispose to another group of antibiotics. So it rarely happens, but it can happen. So there can be allergic reactions like cephalosporin. So it's good to ask questions. It's good to be prepared for in case an allergy occurs. What do I do? If you ever had an anaphylaxis or other serious allergic reactions to any drug, please, it's good if you write it clearly on a bracelet and wear that bracelet all of the time so that in case you are not in a position to talk, somebody will know that this person has had anaphylaxis, because anaphylaxis or any other serious allergic reaction might be fatal if it reoccurs. Now, I will say be at the driver's seat of your health. You see, my experience in practice over the past 3.5 decades thereabouts is that a number of people don't even know the medications that they are using. And that's a problem. So when they have an allergic reaction, it's difficult to know which drug gave them the allergy because they don't know. Please, you should know. It's important that you know. It's important that you keep a record. If you want to prevent drug allergies, you have to be on top of the game. You must remember that it's all about you. Please, please, I keep stressing this and I'm stressing this. Be at the driver's seat of your health. Get knowledge. What I believe in, I'm a Christian, and my Bible tells me in all your getting, get understanding, because knowledge is the principal thing. It's key. People perish for lack of knowledge. Please don't joke about it. Before you put that medicine in, know what it is. At least know the name. Then find out a little bit about it. What can this medicine do to me? What do I expect from it? It's good to know. Please, it's important to know. It's compulsory to know. What you do if you have drug allergy, if you suspect a drug allergy, stop taking the drug and alert your prescriber or pharmacist. Your prescriber should be number one there, but if you don't have access to your prescriber, please talk with your pharmacist so that the pharmacist will advise you what to do. Sometimes that pharmacist may need to engage the prescriber to say, this person has a drug allergy. This is also important because some people, when they have allergy, they just stop the medication and they say bye-bye to it. That may not be the solution. It may be necessary to replace that medication with another one. So that is why it's important to not just stop, alert your prescriber or pharmacist. If your symptoms are mild, they are likely to resolve without any intervention. So after a while, you may the rash, the itch may just resolve. But please note the drug and discuss promptly with your pharmacist or the healthcare professional. Avoid a repeated exposure except under the supervision of your doctor. Sometimes your doctor may still want you to take the same drug that you had an allergy to, but you might, if it's compulsory, because in medicine, we look at cost, benefits against whatever the problem is, the cost benefit ratio. So cost now in terms of the cost to your health. So we look at the benefits. So if that condition without treatment is a big deal, they might just want to try that treatment again, but under supervision, under expert management, and they will provide all the support in case there is a reaction. So don't just take that decision unilaterally, involve them. If symptoms are troublesome, for example, you have rapid falls, difficulty breathing, facial swelling, or your blood pressure drops, please seek medical help as fast as you can. Now, there are some clues that may help your doctor to diagnose your drug allergy. And I have a list here that I called out from a journal. It says, what drug do you suspect? So your doctor might want to know, what drug do you suspect causes allergy? Then when you started taking it, and if you have stopped taking the drug or medicine, how long after taking the drug that you experience symptoms, and what are the symptoms that you experience? Because sometimes the allergy may just be imagined. It may not be real. About a situation where somebody took anti-malaria medicine, called me and said, Mrs. Lawa, I'm reacting badly to this medicine. I'm having itching. My body is breaking. At the end of the day, the patient didn't even have malaria in the first case, even though it took anti-malaria. It was a case of chicken pox. So it was not drug allergy or reaction. So that's why it's good to get all this information. How long your symptom lasted and what you did to stop them. What other medications, including the prescribed and non-prescribed medicines you took? Sometimes we decide to blacklist a particular one. Probably we didn't like the taste. And we say, this is the one that did it. Meanwhile, there are some other ones that probably could have done it. So it's good to get all of this information out to your doctor to help you in making the right decision to be able to diagnose your drug allergy. If you've been on herbal medications, vitamins, or mineral supplements, please say so. Then, what is the history of this drug reaction? Very important. I say this because I've seen so many cases. Some people are taking some herbal things and they will hide it. They will not let anybody know that they are taking those herbal things. Or about the situation where someone say, hey, if you have some doctor, that means will I not tell the doctor that I'm using? But it's important if we don't say it, we cannot objectively evaluate and find out what is happening. So it's important that you open up to your doctor and let your doctor know everything that has gone in there. Now, treatment of drug allergy. Like we said, usually they are self-limiting. Many of them will resolve shortly after stopping the culprits. But for more severe reactions, like the one called toxic epidermal necrolysis, treatments that is given is like that, because it appears like burn. So the patient is treated as if that person had a burn, and it may take many months for the skin to heal. And the next slide may be a bit not very interesting. If you don't like to see a graphic, then you may please just not look at it. It's just to show what this condition I'm talking about is. and it can present like this. So usually this will need treatment by the doctor. Now, our take-home points, drug allergy is immune-mediated. It's not the same as side effects. If you suspect that you have a drug allergy, stop the medication and contact your prescriber or pharmacist. Wear medical bracelets for serious allergies to alert people so that everyone will know that you've had this allergy before. Know about every drug, herb, vitamin, or mineral supplement that you take or you want to take. Please know. It's good to know. Not only because of allergy, there are so many other reasons why you should know. And then be in charge of your health. So I will conclude that by saying that medicines are very important and useful, but harmful effects may occur occasionally. To minimize or prevent such undesirable effects, it's important that we seek adequate knowledge about our medicines and keep proper records. Thank you. God bless you. I'm done.
Thank you, Mrs. Lowell. Dr. Orade, are you there?
I will stop sharing.
Yes, I'm here.
Thank you. We have some questions for for Mrs. Lowell. You want to
Okay,
take
I'll
this,
just
please?
go to the chat. 1 second, please.
All right, if
Thank
you have
you,
any more questions,
Mrs.
just pop them in the chat. Yeah, while we're
Okay,
getting
I'll start from the first one. I can see Jumoke is asking, is it possible to develop a drug allergy after an uneventful previous exposure to the drug? For instance, if you had penicillin previously and didn't react, does this mean you won't ever react to it?
Okay, thank you. Like we said, it's immune mediated, so that means there must have been a prior exposure. So it's not the first exposure necessary that gives you the allergy. So you can develop the allergy despite that you didn't have an allergy before.
Okay, thank you. I hope that answers the question for Jumoke. If it hasn't completely, please post another message in the chat. Thank you. So, and yesterday asks, how do you differentiate between drug allergy and drug side effects in a person presenting with a rash?
Mrs. Lowell, you're on mute.
Okay. Yeah, you were not allowing me to unmute. Like we said, this is just an educational forum. It will be nice to discuss with your doctor so that it guides you. And then we'll be able to know if it's a side effect. Usually side effects are listed on the drug and we expect them to happen. So if it's a side effect, then we'll be able to know because every drug is different or medicine. So you will need to discuss with your pharmacist or doctor.
Fantastic. Okay, so I think those are the ones I've got so far. If you have any questions, please feel free to post them in the chat. If you don't want everybody to see, you can private message the host and we won't call out your names. So yeah, all right. Okay, sometimes, Adebayo, I don't know if this one has been read. I read it out. Sometimes panic attacks mimic asthmatic attacks. Please shed more light on this.
We'll take that later in the Q&A. I think that one is for Dr.
General, okay.
Dr. Latunde. Yes, we'll do that
All
later.
right. And then, can inhaling of black soot trigger asthma in infants and adults? What are the chances to overgrow it while still living in such environments? That's from Coyote.
Sorry, who is that addressed to?
It doesn't say, it's just a question. Coyote, who is your question addressed to? If you're still there,
If
if
not, we can
not,
do
we'll
that
put
later.
it in the general question bank for later.
Yeah, we'll do that
Those are
later.
the two main questions for Mrs. Awal.
All right, that's fine. Thank you. All right.
Okay, and then Somebody said is advising yesterday to also speak with a dermatologist as well.
Yes, that comment is from a dermatologist. Yes.
Oh, fantastic. Okay.
Speak
So
to
the
a dermatologist.
dermatologist is saying you should also speak with the dermatologist. That makes sense.
Fabulous. Thank you very much. Thank you, Mrs. Lawal. Thank you, Dr. Orode. All right, I'm just going to give our speakers a 2-minute break. I'm just going to say a few things. For those who were not here when we started, my name is Flora Coker, and I'm the founder of Encapsulate Healthcare Solutions. And this organization was started to help our community by providing health education webinars to allow us to make better choices and informed choices about our health so that we can all live better, as it were. And the other thing that we do is we provide training for healthcare professionals to improve their skills within wound management. And it's mainly for healthcare professionals in Nigeria and across Africa. So those are the two services we started with. And we're building on that. So, you start with something and then you keep building and expanding as more requests are coming in. So we also now do medication reviews, and we also do specialist medication reviews in the area of mental health. I'm also a mental health pharmacist specialist, and I've been doing that for almost, more than 2 decades. So that we now do that service. We also provide a blood testing service, which I think I've talked about in the past. So you can contact me at encapsulatehealth@gmail.com for more information. All our correspondence is done via email to help with confidentiality, and it's a bit more secure than using WhatsApp. So I know some people don't like emailing, but yes, that's the reason we use email rather than WhatsApp at the moment, because of confidentiality, as you can understand the importance of that. So yes, we have blood testing service, we have a prescription writing service, we do medication review and medication reviews for mental health conditions. And so send me an email, send us an email, and we'll get back to you if you're interested in any of those services. And then the other thing that we like to do at Encapsulate is we like to collaborate a lot. This is all about better health for everybody in our community. This is not a competition. So we do love to collaborate, and I'm sure you've seen us do various things with other organizations. And one of the organizations that we are now partnering with is CoreMed Consulting. I'm just going to share my screen. 1 second. Share. Okay. So CoreMed Consulting, I hope everyone can see that. Yes. Slideshow. Okay. Yes, so CoreMed Consulting, they have a team of prescribing pharmacists specialized in the area of cardiovascular disease, in other words, diseases that affect the heart. So they specialize in cardiovascular disease risk reduction, and they provide hypertension management, hypertension meaning high blood pressure. They also provide service in cholesterol management and lifestyle modifications, including weight reduction, help you to reduce smoking or stop smoking altogether, which is much better, but you can start slowly. So smoking cessation and stress management. And they also do, of course, medication reviews in relation to your heart medicines or cardiovascular medicines. Again, if you'd like to contact them, their email is coremedconsulting1@gmail.com. Now, because we are collaborating and they are very generous at CoreMed, they are offering a free 15-minute consultation. So that means if you email me as well for Encapsulate, I'll have to do the same because, we're collaborating and we have to be nice. So anyway, so coremedconsulting1@gmail.com. We're collaborating with the great company. So drop us an email. And if you have any questions about anything we've talked about tonight, you can also drop me an email at encapsulatehealth@gmail.com. Now, the other thing is, I need to stop sharing my screen now. That's CoreMed. And the other thing is we'll be dropping our feedback link in the chat. Please, please, please do give us feedback. We always want to do better and serve you better. So we'll be really grateful if you could. It's a very short form. You just be clicking. So you can do that while, we're doing the next session, and you can fill it in for the previous sessions and then submit that. So, I don't think I've forgotten anything. I think that's it. And I hope you've had a very informative session so far. So now I'm going to hand back to Dr. Olatunde to talk to us about how allergies are treated, which Mrs. Lawal touched on briefly regarding drug allergies. So Dr. Olatunde, back to you. Okay, there we go. Are you there?
Yes, I can mute myself. So thank you very much for this opportunity to be here. And I'm also very excited to just give back and share information. So let me say, one of the things we do with allergy practice is that there are principles of management. I hope you can all hear me clearly, right? So I'll just start by principle of management of allergy. So if you get these goals and if you understand this, then you can apply it to some of the things I've talked about. So the first thing is to want to educate the patient about what do you want to achieve. I think my video is not showing. Let me try and sort that out. Sorry. I don't know why my video is not showing.
It's okay, Dr. Olatunde, we can hear you.
Okay, sorry. Okay. So like I said, the major thing here is you want to education. So what do you want to achieve? So because you see, the most important thing that people go all over the place because you have not been able to educate them why you are doing what you are doing. So the second thing that is most allergy you cannot provide a cure. Well, I'll talk about the very common cure during this slide. So you are not providing a cure, you are just controlling disease. So it's good to let them know the goal of therapy and what you need to do. Number two is to avoid triggers. Like we mentioned, things will trigger it off. Whatever it is, you avoid it. And we teach people avoiding strategies. How do you avoid it? Then the third thing we do is pharmacotherapy, medications. So we tell you how to use medication and the purpose of medication, and there are principles that you can use for each of the diseases I will talk about. So immunotherapy is like to be a big thing in future. Immunotherapy, what that speaks to the fact that it will modify the history of disease. So we can actually provide a cure. In some conditions, you can provide a cure, i.e. the patient will not be requiring the medication you are giving normally. In some conditions like food allergy, you are not providing a cure, but you are mitigating risk. For example, there are treatments to mitigate risk for peanut allergy. You still carry your EpiPen, but your risk of having severe disease is reduced when you are accidentally exposed to disease. So that's basically what the principle is all about. So I will apply it to asthma. So with asthma, what you do, number one, education. What do you want to achieve? You are not curing disease, you are controlling the disease. And then you teach the patient how do you use the asthma devices, the pump, MDI, the Aquila, tubular, and all of that. If you need to use a special device with mask, without mask, you teach them and you let them know how to use it, and you observe them how to use the devices. The other thing you want to also do is to say, how severe is your asthma? That is an important question you must ask because your medication is tailored along the severity. So generally speaking, in asthma care, we have two classes of medication. We have what we call rescue medication or river medication. So your rescue medication is what you use if you are in acute exacerbation. The commonest molecule in our environment is salbutamol Ventolin, and that's a rescue or reliever to relieve, to rescue from danger. Then the big thing is control medication, and there are many things. It can be ICS alone or ICS with LABA, depending on the age of the patient. And the guidelines, when even some adults, above 12 now, the key medication we use is ICS LABA together, your budesonide, formoterol. So that is you. So, but the general principle is you be on a control medication, and the control medication you have to use every day, like clockwork. And it's like could be a tubular, MDI, with or without spacer. And then the big ones that are like add-on is biologics. At least that is a big one. It's not well. I've not commonly prescribed in this environment because number one, cost is crazy. But if you need to use a biologics, you have to use it. But the key thing I also want to emphasize here is that every asthmatic must have an action plan. When you're doing well what to do, when you are not doing too well what to do, you must have a written action plan. what drug to use, when to use it, when to escalate, when to de-escalate, all that your doctor will help you with that. And every visit, there should be an assessment, how well are you doing, asthma control. And there are tools that can be used to do that. So that's in a nutshell what to do with asthma care. So the other question people tend to ask, do you outgrow your disease as asthma? I will say with a pinch of salt, yes and no. Yes, you have less severe symptoms. But the truth that some people don't really outgrow, what people believe that because you are bigger, your airway is bigger, you don't have very severe disease. True life story, there's a lady and a producer in Nigeria who did very well, but asthmatic, thought she had outgrown her disease, went on the field as a set, had a severe disease after many years, and there was no pump around to help her. She died on set. That is a very sad story. So I would say to you, if you are a non-asthmatic and you are having mild disease, when you are going to a remote area, at least carry a pump with you that can rescue you if you need to. That's the object lesson that we want to pass across. With rhinitis, I said rhinitis will not kill you. So what you need to do, education. What you can use antihistamine. Usually we find non-sedative antihistamine. The one that
Dr. Olatunde, you're breaking and your volume has gone a bit low.
I'm sure that's a network issue. So, but I will just slow down a little bit. I'm sure it's even good I'm not using my video now. So maybe that's
yes, thank you.
So with rhinitis, I said education is also a goal, including action plan, what to do. The drugs we use is nasal steroid, what you apply topically, as the most important aspect of your treatment. That will control your sneezing, running nose, and nasal congestion. Your antihistamine would not control nasal congestion. So sometimes when you have a severe disease, we tend to combine the two. But if it's a mild disease, so your itchy nose, your rhinorrhea, and sneezing, antihistamine will do the trick. But nasal congestion, steroid would cover all that together. Occasionally, when you have very severe disease, we use nasal decongestant. It can be topically, you apply that. But the key thing about topical decongestant that you don't use for too long a period, maximum 5 days, because if not, you have a rebound that will make your condition worse. So, but again, so your doctor, depending on the severity of the condition, can play around with antihistamine and nasal decongestant or steroid and antihistamine. And when you have a mild disease, you can use antihistamine alone. So you can get away with that. So, but like I also said, when you have any of these conditions, rhinitis especially, you should think of asthma. So that is a key lesson. So anybody with asthma, you tell your primary care to exclude rhinitis, because if not, you can still struggle along the line. I will touch on food allergy. So food allergy, what I've just spoken to is the allergic, the type 1. But there are none, like I said, is a big kettle of fish. So in type 1, education is important, but the key thing, you avoid the food. Avoidance is the key thing. So when you go to a restaurant, you tell them, this, you don't eat this, you don't eat this, you don't eat this because you have a problem with it. And then you must have action plan. Action plan is what to do. So if you have a mild reaction, which is just the skin manifestation that I talked about, which is your hives and angioedema, more often than not, your antihistamine alone will help you. But if you have mild reaction with any of the systemic manifestation of respiratory, gastroenterology, CNS, that is anaphylaxis. At that stage, you must use adrenaline autoinjector. Either you use EpiPen or you inject yourself by drawing the molecule from the vial. But that's very tricky to do. And even a doctor, under very severe emergency, can be very, and it takes a long time to do it. I've done it and spent with my husband once. It takes about 40 seconds or more to draw the vial as a doctor and to inject. But for EpiPen is a thing you can do within minutes, if you are within seconds rather. 8 seconds, 10 seconds, you are there. But the problem with EpiPen is expiry date is very short and is pretty expensive. Immunotherapy, I mentioned that that can modify your disease, but will not provide a total cure. In some other conditions, like maybe rhinitis, conjunctivitis, you can actually provide a cure where you don't need medication. But for most food allergy, what has been achieved is you mitigate the risk. So But like I said, there are other non-immune driven food allergy, like what people call about F-pies, colitis. It's not, those are not, some of them will just make sure you don't go, the patient will not go and all that. But that's basically what it is. But the one I want to speak to, and let me also emphasize here, every time you eat the food, you have this reaction. It's important to know that, because I've seen people come to say I have food allergy, and by the time they take history, they don't have anything like that. So it could be aversion to the food, or intolerance to the food, or they just don't like the food. They don't like, they are allergic to the food. I think that's about it. So let me speak to the other thing I actually want to speak to, the CSU, chronic urticaria. For this, what we tend to do is we use non-sedative antihistamine. And you see, a lot of people over-investigate this condition. What you need to do if you have this basic thing, full blood count, ESR, plus or minus C-reactive protein. What you want to do while you do your full blood count is to exclude immune-mediated, IG-mediated type 1 reaction. If the eosinophil count is normal, then you know it's not type 1. It's not acute urticaria. ESR, if it's not rooftop eye, you know it's not autoimmune problem, like you need to see a rheumatologist. And that's because these two conditions, urticaria and hives can be a marker for autoimmune diseases. The other thing we also do is that sometimes people have thyroid issues. Also, you can also have hives and angioedema. So sometimes you do baseline thyroid assay, TSH, and if it's normal, you exclude it. But once we have excluded type 1 IG-mediated reaction, you have excluded autoimmune problems and thyroid function is normal, then you use antihistamine. I've seen people use steroid for a long time. It's not really the right way to do it. What to do is to give antihistamine. You can give as high as 4 times regular dose. And then if it doesn't work, then you have to do biologics. But that's the way it is. But I've seen people manage people with steroid for a long time, and usually we know steroid has own problems, and that is the challenge. And lastly, I also speak briefly with drug reaction. With penicillin, like I said, most people with penicillin allergy, what happens is that they are sick, and they go to the hospital, they are given antibiotics like penicillin or cephalosporin, and they come out with hives and angioedema, and say, is the penicillin. But remember, I said one of the commonest causes of urticaria is infection, bacteria, parasitic infection, viral infection. So that's why we now realize penicillin allergy is overdiagnosed. So if you have been labeled to be penicillin allergy, there are things you can do. We'll take history again. And then if the history doesn't suggest a very likely penicillin allergy, what we do is we do what's called a courage challenge, where you give the person a small dose of penicillin, observe the person. If it doesn't react within 20 minutes, you give a top dose, and that's it. But we usually will take history. And if the history is highly suggestive, there's a protocol where you do the skin prick test with the medication. If it's negative, you do what I just described, drug challenge, and that's it. So that's basically what to say. But with drug allergy, the key thing is to take detailed history. What happened? Mrs. Lawal spoke about 10. 10 is also a form of allergic reaction, but it's type 4. And usually you have 10, you have dress, and a big others on that group. So, but even what we used to call erythema multiforme, we don't really believe it belongs to that group. It's a different entity. But the truth that with drug reaction, you can have that severe Stevens-Johnson syndrome of 10, but history will let you know what to do. So the key thing is history for most allergic condition, and you can decide which track to go. So if there are questions, I'll be able to answer the question about treatment. We'll go to a lot of details. Thank you.
Thank you so much, Dr. Dushote. All right, before we take some more questions, I'll just give you a break of 1 or 2 minutes. Mrs. Lawal is also one of our collaborators. Mrs. Lawal, please, could you just unmute yourself? And if possible, put your video on. I just want you to mention some services that Victory Drugs do in Lagos, Nigeria. I just want to give Dr. Bishote a short break. Maybe you can have some water or something before we take the rest of the questions.
Good evening once more. So I work for Victory Drugs, and we also believe very much in collaboration, and we do a lot of collaborative practice. We have a standalone vaccine clinic where you can get your vaccines. We also do medication use review, and we generally focus also on preventive health. So we help you to assess your risk of certain conditions so that you can work on those risks to minimize them as much as possible. So we do the core pharmacy thing, that is to make sure that to help you with your drug therapy, to be sure that you're taking the right thing with support for adherence and a host of other services that you can access from us. Thank you.
All right. Thank you, Mrs. Lowell. She doesn't just work there. She owns Victory Drugs. I don't know why you said you worked there. Yes, of course you work there, but she's the founder as well. All right. So I mentioned Med Consulting previously. The CEO and founder is online as well. Mrs. Ikwama Udaja, she's put the email in the chat as well. But if she wants to say hello, just let me know, and then I'll say you should unmute. All right. So while we're going to go to the Q&A. If you have any more questions, pop them in the chat, but I'd like to make this section very interactive. So if you could put your hand up as well, that would be great. So we'll start with some of the questions that were dropped earlier on. So I would just put Mrs. Lawal and Dr. Dishote on spotlight, and then we'll take it from there. Okay, so the first question was to do with penicillin allergy. And the question is, if one has been diagnosed with penicillin allergy years ago, is there any need to have an allergy test done? Who wants to take that?
I think Dr. Bishop already spoke to that, because we found out that penicillin allergy generally has been overdiagnosed. So you may just want to talk with your doctor, dermatologist, allergist, and then they might want to help you know if indeed you have this allergy.
All right. Dr. Jusota, do you want to say anything else?
Well, I think that's what it is. You need to detail history of what happened in the past, and then if there's a risk, then there are other tests you can do to. Is that whether you still have the allergy or there's not really allergy in the first place.
Okay, thank you. All right. So just raise your hand if you have any questions. Sometimes, the next question, sometimes panic attacks mimic asthma attacks. Please shed more light on this.
Well, I will say this, history. Panic attacks, there are things you look out for. And that is usually circular based, a few things, and it will go away by talking to the person, you can talk the person out of it. Like I said, asthma has a telltale sign. Family history, wound, as it will have, there are things you have seen and all that. And then there are tests to do, and then there are, when you even listen to chest, you won't have wheezing panic attack. And you won't have wheezing chest and all that. You see somebody's worried, who has a trigger, is worried about something and all that. So history will easily help you out with that. Thank you.
All right, thank you for that. All right, so next question is, can inhaling of black soot trigger asthma in infants and adults? And what are the chances to outgrow it whilst living in such an environment?
Well, see, what black soot will do to you is to modify your airway. Your risk of respiratory infection is higher. And we know that if you, but see, the key thing is that you must have that tendency, atopic tendency. Like I told you, you have to have the tendency. So we also know viral infection can trigger asthma attack, right? When you have inhaled soot, you modify your airway. Things that are supposed to help you clear your airway is damaged, ciliary motion, and all that. So things get further down to your airway. So I would say to you, if you have that tendency and you're in that environment, you are at risk of respiratory infection, and then you can have your asthma getting worse and all that. Because that will be a lot of infection of the upper airway, and that's the danger of you put yourself in.
All right. Okay. Thank you. Next question. Another question about eczema and psoriasis. Please, can you shed more light on eczema and psoriasis, please?
So, okay, well, if you without sounding, so if you look at eczema, right, eczema has a telltale sign, i.e., pruritus, typical rash that comes on and on, distribution, family history, personal history of atopy and all that. But that's in a light traveling straight line. But because I also know in some other clients, for example, if you're talking about Asian population, we now know from data that even psoriasis in Asian population can look like atopic dermatitis. But for this discussion, let me just put it a light traveling straight line, is that there, if you take detailed history, you can differentiate between the two. But we know, like I said, the data that says in Asians, you probably will not be able to, there's some crossover, but that's high stuff, which I don't want to bother us about. But in basic people, you can differentiate between the two. That's the bottom line.
Okay, thank you. Let's see. Someone saying thank you for the insight on penicillin allergy. All right, next question. Is dermatographia a form of allergy or just a skin disease? The person in question only had symptoms of dermatographia when she lived in a house painted with a certain blue paint. First of all, Dr. Dishote, please tell us, what is dermatographia?
Okay, so it's actually dermatographism. What is called,
Okay.
it's called skin writing. So it's like, I can actually write my name on your skin.
Wow.
So if I write, so that's the, so it's a form of pressure urticaria. So is that mean your cell, mast cell are very twitchy. They release histamine, you have those things. So sometimes when you have people who have chronic spontaneous urticaria, one of the things you do to exclude pressure urticaria, you do that, the skin writing. So most people that I've seen is not driven by what they heal, it's pressure of the skin. So it's called skin writing. More often than not, you can live with it. Most people have not had cause to put anybody on medication for that. But if they have pressure urticaria, and every time they wear tight clothing and all that, and it comes out the hives and all that, then that's when we say, look, during that trouble season, you'll be on histamine. But that's basically what it is. But with painting, I have not come across anybody, usually with pressure, or you write on the skin. So it's called skin writing. So you can actually write a name, and you see the name on the skin for some time, and it will disappear after a while.
Wow. Okay. And is that something that can be treated? Does it go away, or?
So like I said, for most people, just reassurance and all that. But if it's troublesome, antihistamine will do the trick.
Fabulous. Okay, thank you. Any more questions? Okay. Does hay fever relief become less effective after prolonged use? The person says they used on their son with severe hay fever during pollen season. So does it become less effective after prolonged use?
Well, I don't know what has been done. So like I said, there is stepwise approach. So if it's very mild one, they will say just use antihistamine alone, right? During that pollen season. If it's very bad, you will combine steroid with antihistamine. But I also know sometimes some people, when they're on, I've seen people like that, they will put on antihistamine, they're not getting help, you change another one. So maybe you are on Zizal, it's not helping, you can go fesiphenidine, or you go to this loratadine and all that. So you can actually play around with some of these things sometimes if they're not being helped. So that also, it's a known entity that people do. So sometimes we switch medication and see how they can help. But usually it's good to take detailed history, compliance, do you need to scale to steroid or antihistamine and stuff like that. That will be my own approach.
Okay. Now, okay, next question. What causes the allergies of G6PD to be triggered as you get older? And you know what I'm going to say, Dr. Dishote. What is G6PD for everyone's knowledge?
Okay, so G6PD deficiency, that's glucose 6-phosphate dehydrogenase deficiency, it's not an allergic condition, right? It's like your red blood cells lacks that enzymes. And because they lack that enzyme, it's will be unstable, right? And there are things that can make it break down. So fortunately for Africans, we don't have very severe form of it. So, so some people, if they have G6PD deficiency, when they eat fava beans, their red blood cells get broken down easily. But for Africans, at least, what we have is minus A1. So the thing that's been documented in literature in Nigeria, that if you know, there's what we call rest syndrome, is a preservative they have to suya that makes it look red and attractive. So when they eat that, that will break down their cells because the cells is deficient in the enzyme. So the G6P is supposed to be something that acts to help you more to make the red blood cell stable. I want to talk in layman's language. That's what it is. So it's not an allergy. So if you have deficiency, then your red blood cells become unstable when they're exposed to certain drugs or certain condiments and some environment. That's what it is.
And does the G6PD, does it get worse or get better with age, or how does it work? Or does it never go away?
So the truth never really goes away because it's a deficiency. But like I said, in Africans, we have the type that really the older cells, the older your cells become, that's when they manifest that deficiency. So you don't have the kind of severe disease that you see in Mediterranean people, in Arabs and other people. So the only time we see it in this environment is in neonates when they have neonatal jaundice, when they are exposed to camphor and stuff like that. So that's basically what it is. But most people don't have severe form of disease in Africa.
Okay. And the same person is asking, what can be done to stabilize it? Does it progressively get worse, or does it stay the same? Or
like I said, it's like you is an inheritance, something that is with you, right? You have deficiency of the enzymes. Like I said, what we have is very mild one. So it's the older cell, red blood cell that you have that usually, as they get older, they are not as efficient, right? So it's what you need to do so like I said, most people don't have when they're older, they don't have, there's like I said, there's on drugs. But even in Nigeria, because we have very mild form, we don't see the impact of those drugs on our system. But so it's not something you can, except you do genetic engineering where you modify your genes. So, but it's there. But like most Africans have very mild form. So there are drugs that can make it worse. So if you are exposed to one of those drugs, like naphthalene balls, and some other clients, if you eat certain kind of beans, they actually have severe anemia. The red blood cells is destroyed, but we don't have such things. But you cannot grow it because it's a genetic thing. That's basically what it is.
Okay, thank you. So are there any allergies that are more prone to be seen in Africans? Are there any specific allergies that you see more frequently rather in Africans?
No, you see, more often than not, I think what is happening here is that we are in denial. We still think allergy is a white man's disease, right? That's a major problem. See, I also believe that because what you look for, that's what you see, right? If you don't look for it, you don't see it. If you don't look for it, you don't see it. So as you look, you see. For example, when I trained as a dermatologist, I was told that psoriasis is not common in Africans. Well, when I started seeing psoriasis, I said, it's here now. So when you look, you see, right? So I think what has happened the problem with allergy is that our language cannot describe disease. For example, if you ask me, what is wheezing in Yoruba, I will say Igbo. There's no word for wheezing. So you must have to describe what it is for them people to. So that's the problem. So it's case definition in our languages culturally that will help us to identify more disease. And then as you train more people, as you empower more people, as you do education like this, then people say, okay, what he talked about is likely to be what I have. So for me, it's education, and then people can say, hey, what it described look like what I'm going to. For example, one of the things that I'm passionate about is primary immunodeficiency. So we know about secondary immunodeficiency like HIV and all that. But the truth, in Africans, there's primary immunodeficiency. But nobody's looking at it. Nobody's, because we don't know what it is. So if you don't know what it is, you see it, you say maybe the village people, they have come again. That kind of thing. So, but it's some of things. So I think with action like this, we can empower ourselves, people can go seek help, and we can describe so there's nothing, everything that we see in the white people population is here. But the only thing I can say, environment, as we get westernized, let's put that way, we probably see the incident. From data, for example, Blacks, Africans living in Europe will have more incident of atopy than they live in Africa. Okay. But if you look at our population here, people who live in the high socio-economic class will have more incident than people who live in my village, for example. Because even in Europe, people who live very close to animals have lower incident than people who live in urban areas. Is a known thing, especially if you have. So the key thing, atopy, your tendency and the trigger factors. So once we can modify your trigger factors, it's a like, but I believe with our lifestyle. So one of the things I usually joke about is that the people was told us when I was in medical school if you are asked in medical exam, cause of sudden death in an African man, if you mention myocardial infarction, you will fail the exam 20, 30 years ago. But if you say, it's from the village, you're likely to pass on the right note. But now, MI is with us. Why? Lifestyle, what we have been doing with ourselves and all that. So that's the kind of thing I believe that non-communicable disease, like we also know, is on the rise in Africa, because one, we're able to define the disease entity properly, and we know our lifestyle has changed over the years. That's what I say.
Thank you. Mrs. Lawal, did you want to say something? No? Okay. So we have a question. Please, my triggers are always in the rainy season, but disappear during hot season, except I inhale dust. It started as little allergies with watery nose and eyes, and gradually came up as my older years to asthma. What are the medical routines I can take? Okay, for the person who has put that question in the chat, I think that's what you need to see your doctor for proper assessment and diagnosis. Like we said, this program is for educational purposes. We're not doing any diagnosis. So it is best to see your doctor for that, so you can get a proper assessment. All right. Okay. Dr. Dushote, if people want to get in contact with you, what's the best way they can get in contact with you?
Okay, well, I run a practice which is allergy and asthma clinics in Lagos. So if you type my name, on Google, my name will come up. On LinkedIn, you'll see me, and I have a website also. You can also, my name will come up, and there's a way to just by WhatsApp and all that, and email.
Okay. Could you please pop your email and your website in the chat for us, please?
Okay, I'll do that.
Then people can just access it that way. Okay, do we have any more questions? You can raise your hand, or if we have any healthcare professionals online who want to comment or chip in about the topic we're discussing today, then please raise your hand, and then we'll ask you to unmute so that we all learn together and share knowledge. Before we close, anyone else? No? Okay. Another question. What can you do to treat a peanut allergy that occurs at home without an EpiPen available? The person says her daughter develops angioedema and sometimes has vomiting, sneezing, itching nose, etc. She usually just uses chlorpheniramine. I was trying not to pronounce the brand name. Say the brand name. That's the question, Dr. Dushote.
Well, I would say it's best for you to see your physician. See, what you describe is an overlap between a mild disease and possible anaphylaxis. And you need to be properly assessed, i.e. they can do a skin prick test, your blood level of IgE and all that, especially IgE for peanuts. And then they probably tell you you need to carry an EpiPen. If it's skin infection, your antihistamine is going to be good, but I think you need proper guidance because anaphylaxis can be very tricky.
Okay, so but this person is saying that, her daughter has, when she has an peanut allergy at home, what can she do to treat it if they don't have an EpiPen?
Well, see, if it's anaphylaxis, if you have it, you must have adrenaline vial that you can draw. They'll tell you the dose to give, and that's what you need to do. Because, you see, you don't know when you have a severe disease. It's like, I tell people, the way I describe that is like you want to ride a power bike and you don't want to wear your crash helmet. You can be riding your power bikes and you are safe for 10, 15 years. But the day you get a very nasty thing, your crash helmet and the gear to wear will protect you. So what I will say to you, EpiPen can be very tricky even in Western world to assess. But the least you have a vial of adrenaline and its needle and syringe. It could be tricky, but should be trained how to use it if you think it's anaphylaxis. And for your child, I think you have a written plan. What to do with a mild disease, what to do when you have anaphylaxis. If you don't have access to EpiPen, they should give you a couple of vials of adrenaline at home and then some syringes and needles, maybe 2cc syringe. You can actually draw 0.5 mils of that and give into the muzzle, lateral side of it. And they can call for 911 and they can come and evacuate. It's better to actually over-treat anaphylaxis than the treat. That's what I would say.
Okay. And an important point is that one of our colleagues has put in the chat, anaphylaxis cannot be treated at home. It is an emergency. It's important that you take the child immediately to the emergency if there is no access to the adrenaline to treat it. So please, anaphylaxis, as we've mentioned several times before, it can be fatal. So it is an emergency. It cannot be treated at home. All right. Okay.
So can I modify
Yes,
that? What I would say
yes.
that initial care can be started at home, i.e. EpiPen, adrenaline, right? Should be done at home and then call 911. What we should say, once you have an anaphylaxis, give adrenaline, EpiPen, and then call 911 and go to ER for continued care and assessment. That's what I would say to that. But that's a very wise advice. Don't stay at home, do what you need to do, but you must get to ER. After even giving an adrenaline or even suspended anaphylaxis, you must go to ER.
All right, okay. Okay, last question, I think. Someone is saying they had an experience with chloroquine. So I had an experience and had itching due to chloroquine allergy. Is it possible to overcome a drug allergy after the body gets used to the medication?
You see, what we talk about chloroquine is not really an allergy, right? It's not. See, allergy has to be driven by the immune system. What you have with chloroquine is adverse drug reaction, right? The information down the line actually shows that the reason why, and that's why they give antihistamine. That's what so it's not an allergy, it's an adverse drug reaction and you give antihistamine. But the beauty of that antihistamine that we gave was that the chloroquine, the malaria parasite used to pump out the drug from the red blood cells, but the antihistamine actually blocks that pump. So in Southwest, where they use that drug a lot in those past, that antichloroquine resistance was not as common in our climate until very lately compared to other part of the country where they don't use antihistamine with chloroquine. So it's not an allergy reaction, it's an adverse reaction to itching. But we also found that when you give antihistamine, it actually blocks the pump that malaria parasite used to pump out the drug from cells, and then we have a longer lifespan for chloroquine in our own Southwest and other part of the country before chloroquine became useless. Thank you.
Thank you very much, Dr. Dushute. And Mrs. Lawal, thank you. If there are no more questions, okay, there's one comment. Yes, exactly. It's better to overtreat than to undertreat. Absolutely. Thank you so much, everybody. I can't see any more questions in the chat. No one's raising their hands. I've just put the link to the recording in the chat. Please don't forget to complete our short feedback form and let us know your thoughts about today's webinar. So on that note, I'll say thank you and good evening. And